Next on Primary Care, Heart Health. Research shows that changing your lifestyle can lead to a healthier heart. Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. According to the American Heart Association, nearly 48% of black women and 44% of black men have some form of cardiovascular disease. Many factors contribute to these alarming rates, including unhealthy lifestyle choices, ingrained cultural preferences, attitudes, genetics, socioeconomic and environmental factors. With so many issues to contend with, what can African Americans do to take better care of their hearts and decrease their risk of cardiovascular disease? We invited Dr. Kim Williams to help answer that question. Dr. Williams is chief of the Division of Cardiology at Rush University in Chicago. He specializes in cardiology and prevention and has studied how disparities contribute to heart disease in the United States. Dr. Williams, welcome to Primary Care.
Thank you for having me.
We're so pleased to have you on the show. I am in awe of all of the things that you have done in this area of heart disease and prevention, and we're just amazing that we were able to take some of your time for this program. Heart disease develops in our population at a younger age as opposed to other groups. As you know, knowledge is power, and what we do to communicate this message to African Americans about heart disease has been lacking. What can we do to get this message out?
Well, first of all, people need to know what their history is. And if we actually sit back and look at the history of heart disease in the United States, not just the African American population, it's been the number one killer of Americans since 1918. And we thought that COVID-19 would take it out in 2020. It didn't make it. Still number one. And that the United States is the only high-income country. So sure, low and middle income countries, actually heart disease is number one, but the only high-income country where heart disease is still number one is the United States. And so we have to look at ourselves as a culture. And then what you're asking is about the subculture. So the African American population has a mortality rate from cardiovascular disease that's 21% higher than other races. And so that number one position is really driven by us. If we just fix ourselves down to the horrible rate of heart disease that everyone else has, we'd actually not be number one.
That would be an improvement.
Yeah. Exactly. And so what are the issues? Sure, as you mentioned, there are social factors, there are environmental factors, but there are also the historical factors of what people like to say, the lifestyle that we've adopted. And we went from, being very physically active and throughout our history, forced at first, and then by need, of course. And then you get to the point where people have luxuries and people will not exercise because they don't have to anymore. And they're eating the kinds of foods that do not promote longevity. So we talk about a variety of diseases that are higher in the African American population, particularly hypertension. But it's also diabetes and obesity. And when you look at all of the outcomes of those diseases, the heart attack, stroke, heart failure, peripheral artery disease with amputations, and a lot of healthcare biases and unfortunately demonstrated implicit biases in the medical care that do not help us with those problems as well as they could. If you put all those together, you've got a situation where we have a lot of unnecessary death. We have a lot of unnecessary expense, and people are not actually realizing that when you get a heart failure, for example, that's an expense on your family. They're taking off work to take you into the hospital. The worry level that your family has, it's more than just dying. It's actually living in an unhealthy life. And so what can we do? We need to fix the underlying factors. And if I had to pick one thing out, it would be nutrition. Plenty of people have talked about it, so I'm not the first to point it out, but we sort of grew out of a system of eating taking what they call low on the hog. We've heard that over and over again, where the things that were being thrown out were the things that we figured out how to make it palatable. And unfortunately, even though the Emancipation Proclamation was in 1863 and we celebrate Juneteenth, there are parts of us that are still not liberated. And one of them is nutrition. And the kinds of things that have been pointed out most recently in the medical literature, the Southern diet, which really is a nice medical way of saying soul food, where you take greens that are healthy and you put salt and you put fat back and
salt pork. Yes.
Exactly. You put those things inside something that's healthy, and it may make it taste better if that's what your taste is, but you're going to pay a penalty on the other side. So that whole thing of sugar sweetened beverages, saturated fat, sodium, animal protein, you put all those together and it generates more in our population, it seems, than others. But I'm not sure that there are any Americans who actually tolerate that diet. It's just that we eat a little bit more of it. And the result is a higher mortality. I always, as a cardiologist, sometimes fail to remember to talk about kidney disease. It's people with kidney disease do not die of kidney disease in our country. They die of heart disease. And so
Absolutely.
we lump that in because, the literature is so clear that it's nutritional, that animal protein, particularly red meat, but animal protein is toxic to kidneys. And then you think about the arteries of the heart, and then this magic little 4-letter word that I hope everyone will look up, since we don't have time to talk about it for 2 hours, which is what it deserves. It's TMAO, trimethylamine N-oxide. If everybody will put that in your search engine, and your jaw will drop, and you'll never eat any animal products anymore, because the components of the animal products is phosphatidylcholine, choline, betaine, creatine. They all mix up with the non-vegetarian type of bacteria that are in the person who's eating the usual American diet. They have bacteria in their gut that are very toxic, and they make you sicker from COVID. They make the kidney disease, they make the heart disease, stroke, and heart failure. And it's hard to imagine that everything that's going on with our nutritional system is filtering through bacteria in our gut. But that's the new science that I hope everybody is paying attention to. Everybody should look up TMAO and then stop eating the products that help generate it.
That's very interesting you should mention that, because at the end of the day, it's inflammation that we're dealing with. And it's funny you should mention that our renal patients don't die from renal disease, they have heart attacks. Same thing with my lung patients. They don't die from respiratory failure or COPD. I can keep you going at home on a ventilator, but they die from myocardial infarction, and a lot of times that underlying disease state has been missed because we're focusing on a different organ system. Dr. Williams, we need to take a break, but when we come back, in our Black Lives and COVID series, you'll hear from a heart attack survivor who's taking special care of himself and his heart during COVID-19.
Whether it's advice on managing your anxiety or tools to help you stay grounded, Coping-19 provides a range of resources and self-care tips to help you cope with this pandemic. We can help. Find the resources that work best for you at coping-19.org.
COVID has had a devastating effect on the Black community, and because of this, we decided to give a voice to members of our community to share how COVID-19 has impacted their lives. Today in our Black Lives in COVID series, you'll hear from retired DPS logistics manager Leon Grant. Mr. Grant is a heart attack survivor who feared getting COVID. He shares his story.
Toward the end of my career, the last 3 years, I had a heart attack. And I was stunned because I thought I was pretty fit. But at that point, after I had the heart attack and a triple bypass surgery, by the way, I retired in 2010. Upon my retirement, I just tried to maintain my heart health with exercise, medication, diet, and I was very active, very active. Then in the COVID, it's a whole different situation because I became quite fearful hearing all of the news, information, misinformation, re-information, debates in terms of the factors involved with the virus. Having the factors among them being a heart patient, over 65, diabetes, and some other issues. Of course, I consider myself at very, very high risk. I caught a little cold shortly after the beginning of the pandemic, and I was nervous. What do I do? Do I go to the doctor? But I had heard of some friends said their doctors turned their backs on them, and that frightened me, because they said, go home and quarantine. What does that mean? So oddly enough, I found my best information on BBC Radio, because sometimes the American broadcasts were a little sensational and this and that and the numbers, but I found some common sense best practices on BBC Radio. Because they said, at one particular program, they had a whole 30-minute program on heart patients and COVID. So I said, wow, this is what I'm looking for, because as a heart patient, I knew I had to be extra careful, because I have all the risk factors. Vaccinations, that was interesting. I got all the vaccinations that I could, but I got them from CVS. And because I know my doctor, when I visited her, my primary care doctor was upset, I said, listen, I got the vaccination where I could get them. I couldn't reach you by phone or by email, so when the CVS had told me that I could get the shots then, I took them right on the spot. Almost back to normal. I still, although I've had both vaccines, I've made sure that I still practice mask wearing and distancing, because I really do that for the younger children in my family. Under 12 who come back, I make sure I still, whenever they see me, I have a mask on. Even if it's a short connection, I still try to make sure of that. And I intend to wear my mask for a long time.
Dr. Williams, in our video, Mr. Grant was doing many things right given his condition and especially his heart situation. Should patients with heart conditions be concerned about getting vaccinated?
So this is something that is really important to talk about. I know there are even colleagues and friends of mine who are against the vaccines, but if I had to get one point across, that people who have cardiovascular disease, respiratory disease, like you mentioned, diabetes, obesity, high cholesterol,
yes,
and hypertension, these are the people who have worse outcome with COVID. And so when you mention that, the effect of COVID on the Black community, there's actually data from Rush, but we were scooped by the Oceaner people in New Orleans. They got it published in New England Journal of Medicine, but our data agreed with theirs, that being Black actually was slightly protective against mortality with COVID, if you adjust the model for the risk factors. So it's risk, not race. If we're an obese population and obesity leads to more cell entry and more cell reproduction, more viral reproduction, then we're in trouble. But if you correct the model for all of the underlying diseases, we don't have an increased mortality. So it's us, it's what we're doing. So the reason that everyone should be vaccinated and follow the CDC recommendations is that we have to stop replication. Now we've seen it. We started off with COVID-19, and then you had the Israeli, and then the UK, and now we've got this Delta variant, and it's much more contagious. People don't realize that when you say natural immunity, you're allowing an imperfect virus to reproduce itself. Wouldn't it be great if it could make billions of copies and never make a mistake? But that's not reality. That's not biology. It's going to make a mistake. And some of them are going to make it weaker and it disappears. And some of the mistakes the mutations are going to make it stronger. And that's what's happening. So anyone who's saying, don't get the vaccine, go ahead and go for natural immunity, you're allowing this thing to continue to progress. And now we're seeing people who are vaccinated. Is it because the antibodies are going away? Or is it because the Delta variant is just different? There's protection, and it's a lot of protection, but it's not complete. So it's, we really have to get a control of this. And I would say anyone who has heart disease, the only time to consider is that if you have some horrific immune disease already, and the advice is to be careful with it, I could understand that. And then there's some people who have actually had COVID who tend to have more symptoms after a vaccination because they already have some immunity to it. And I'm not saying that it's an easy decision for everyone, but for their general population, particularly anybody with risk factors and heart disease, they really do need to go in and get this vaccine now.
Dr. Williams, you talked a little bit about this diet and, traditionally in our history, we were more active, number one, as a community, and number two, our diet was simpler. It wasn't convoluted like we're challenged with today, especially with fast foods everywhere and the convenience of unhealthy substances that we have to take in. What is the problem in terms of us addressing this issue? Are we not getting this message out adequately as providers? Does our community need to take on a different role in terms of helping patients understand that we're doing it to ourselves? Where are we going wrong?
I would say that we've got several issues, and some of it's cultural, as you mentioned, but a lot of it's economic. The cultural side is that we learn to eat from our parents, and our parents were taught unhealthy lifestyles that they inherited. And at some point, we have to break the chain. We have to have the nutritional health literacy, because there's loads and loads of things that we didn't know about in the past, and now we do. Refined grains, eating sugar, having saturated fat, instead of polyunsaturated or monounsaturated fat, eating cholesterol. Each of one of these has its detriments to the cardiovascular system and the rest of the body as well. And so if we get that literature out there, if we get it into the grammar schools and we change to healthy snacks, instead of soda pop, we have water. Instead of, if people think that juicing is good, well, if the fiber goes in the garbage, it's not good. And there are things that we know now that we need to spread throughout our educational system and have the children lead the parents in many cases. So I have a lot of good memories of the Obama administration trying to do this. Michelle Obama had a food czar, and they were doing this in Norfolk, Virginia. And the effect of changing the food in the schools really did make a difference for the families. On top of that, we have the economic issues of marketing. There are people who are marketing things that are toxic. And unfortunately, you mentioned fast food. We have a very high density of fast food in the African-American population. And the estimates are that 1/3 of all African-Americans eat fast food every day. And that's just a tremendous burden of the things that sell. And what sells? It's the so-called SOS. It's the salt, oil, and sugar, all of which make us gain weight, become insulin resistant, promote diseases, and it's a cardiovascular burden that we can't tolerate. Now,
It's as high as 1/3 in our community, or is that a national figure?
That is a national figure, and that is I'm sorry, worse than the Black community.
Okay.
That is, and that's and so when we look at why is it? I think it's marketing. There's two other things we should talk about. The marketing, we actually did a study. Actually, my granddaughter started it, and hopefully, with a little bit of hard work, we can get it published really soon. I'm going to do those edits today. We're looking at television commercials, and just going through the American College of Cardiology's journal had a nice article about healthy versus unhealthy. It was actually talking about unhealthy plant-based diet as well as animal products. And it gave a nice scoring system. So we took the scoring system, put it on the commercials. And the fast food restaurants are the more frequent commercials. They're on during children's programming, and they're promoting unhealthy food, refined grains, the animal products, the saturated fat, all of it. The next issue is our Congress. That is, we've never had the determination that we're going to save healthcare dollars, even though we spend more on healthcare dollars than any other country per capita, and we have some of the worst outcomes. And so what are they doing? They actually have congressional subsidies for production of foods that are unhealthy. And if you do that, you make them inexpensive. So people who are economically depressed can gravitate toward those foods because they can afford them. And then Congress has to pay for Medicare on the other side. So you're actually paying into a system to ruin the health of the American population so that you then have to cover that. And, I always like to talk about it if I had a second about Medicare. I was an advisor there for 4 years, and I came out with a tremendous amount of respect for what they're trying to do. They were supposed to go broke, according to the Medicare trustees, in 2026. Now they're saying 2025, 2024 because of COVID. Well, why were they going broke? It's mostly cardiology and primary care. Okay. That is, we're taking people and we're not curing them. We're managing their disease, and we're managing so well, stents, bypass surgery, statins, that they're living longer than they otherwise would. And so that actually is not affordable. So what it would help the insurance business is either come off the rolls because you pass away, or get well. Well, of course, we would want to choose for people to get well instead of just managing disease. And so what I'm hoping is everyone will recognize that a healthy lifestyle, particularly plant-based nutrition, exercising 150 to 300 minutes a week, making sure that your weight is under control, knowing what your blood pressure is, knowing what your blood sugar is, knowing what your blood cholesterol, not smoking. Do you do those 7 things, the so-called American Heart Association Life Simple 7? You do those things, then you're actually fulfilling your patriotic duty to the country and the finances, and because we don't do roads and bridges and education for poor kids if we're spending it all on healthcare. It's just not going to happen.
Dr. Williams, I can't let you get away without at least touching on this, because I know it's near and dear to your heart. We suffer from a lack of cardiologists who serve our community, who look and represent what the African American community is all about. When I know when you were here in Detroit, I think we had one African American fellow in training during that time, something that we continue to attempt to address. Where are we heading in terms of the overall numbers in terms of training programs?
We really do need help. And, we've gotten a lot of attention, American Medical Association, American Heart, American College of Cardiology. We have a diversity, equity, and inclusion task force that just turned into a committee, and I co-chaired it for 4 years, trying to figure out, and my task really was to try to partner with everyone we can. I mean, you name it, we tried it. Talk to the presidents of the HBCUs, the historically black colleges and universities, about getting more people interested in pre-med. We've talked to community groups. You may have heard of Jack and Jill, and they bring their kids to a lot of different places, but why not medicine? Then there's Links, Professional African American Women. And these kids from professional African Americans, they're going to go to college most of the time anyway. But why not think about science and about medicine, and particularly and cardiology? And one of the organizations that we've been working with is the rapper actor Common. He started the Common Ground Foundation. And these are the poorer inner city kids. And so come the places like the DPS and the Chicago Public Schools, where they take them and expose them to things that are really going to change their lives and change their perspective. Take them to Google, take them to Amazon. And it turns out that they got them to come to Rush University. And we're really trying to give them the perspective that you can be a cardiologist. And if you can see one, you can be one.
Absolutely.
But if you don't see that as a role model or someone that you can look up to and say, hey, Dr. Williams came from a humble South Side of Chicago inner city background and Chicago Public Schools, and if he can do it, I can do it, and that is actually the case. And so I've really been working on the pipeline, and we have a particular pipeline right now with African American men. It's the African American young ladies, they get it. And they're going to college and they're applying, but the men are straggling. Now, why is that so important? It would be nice in the ideal world. It wouldn't matter what your race was or where your gender was, and to relate to a patient, and all doctors could relate to all patients. Unfortunately, that's just not reality. And it turns out there's a very shocking publication that showed that African American men who have some of the worst health care, presenting late with diseases, ignoring diseases, of all of the Americans, it turns out that they respond better in terms of complying with primary care recommendations if it's an African American man who's giving them the advice. Now, that's unfortunate, but it's reality. And so, the Hispanic patients really do seek out our Rush Hispanic doctors, not just language, but culture. And so this is the reality, and we have to right-size the medical staff for the population that we serve. So we do need more Hispanic, more Native American, and more African American doctors, particularly men.
So you're really speaking to goals, timetables, outcomes. in terms of where do we want this to be 10 years from now in terms of the numbers. If we don't start now, we're going to continue to fail and pull up a poor performance that nobody's going to be satisfied with.
Absolutely.
Kim, tell us a little bit about what's coming down the pike. You know, recently we had new indications for a diabetic drug in terms of treatment of heart failure and preserving kidney function, both very, very important to African Americans looking at the numbers. Tell us where we're going with that and how we in primary care should be instituting that into our program for treatment of patients.
So I don't want to take too much of a tangent, but I have to, as I've done many times in my career in leadership of the American College of Cardiology, talking about our problem with drug pricing in this culture. We need to get a hold of this. Why did I shift over to that? It's because you're absolutely right. The SGLT2 and GLP-1 inhibitors, these are unbelievable drugs for the heart. They can decrease the blood pressure, the heart failure, volume overload. They decrease cardiac events. We think we're so big and bad with statins. Well, statins are actually pretty good, but the outcomes with these drugs are just as good on top of the statins. So if you lower episodes of heart attack, stroke, and death and heart failure by 25% with a statin, and then you do it again with one of these drugs, that's great. So what is the biggest barrier in my practice to implementation is that the people who are well employed and have good means can get the drugs. They've got to do something about the pricing. This is really critical in my view. So yeah, I should have started where most of cardiologists are starting these days. If you're aware of the literature, and I think everyone is at this point, this is no longer just primary care or just endocrinology. This should be bread and butter. Excuse the aphorism. Okay. Cardiology. This is the what we need to be doing for our patients who are diabetic and even pre-diabetic. And these drugs are fantastic, and they have great outcomes. Let's get on it both educationally and then let's fight for better drug pricing so that our community can get them.
Basic tools that we should be using. Dr. Williams, thank you so much. It's been an honor and a pleasure to have you on the program today. We'll have to do this again because I told you at least 200 more questions to get through here. And this is an exciting topic. Good. Thank you so much.
All righty. Take care now.
Our guest has been Dr. Kim Williams, Chief of the Division of Cardiology at Rush University in Chicago. Heart disease is the #1 killer of Black men and women, but it doesn't have to be. African Americans can improve their odds of beating this disease by understanding their risk and adhering to a preventive, healthy lifestyle. For Primary Care, I'm Dr. Lonnie Joe.